Hello and welcome to Expert Perspectives in Cardiology. I'm Harriett Seager and I'm honoured today to be joined by Professor Pedro Brugada, discoverer of the syndrome that bears his name and also chairman of the cardiovascular division at the Free University of Brussels. Welcome today, Professor Brugada.
Thank you. Welcome.
Very nice to have you here.
I'm really happy to be here.
Fantastic. So if we go back a little bit in history to start with, and can you just tell us a little bit about how you got into medicine in the first place?
Well, that's a little bit of an awkward story because, I'm coming from a farming family, and I was quite happy during the summertime to help my father, and then I got quite acquainted with, the whole business of the farming and rabbits and chickens and eggs and all these things. And at the time that, I became 16, I wanted to take over and just help my father. But my mother simply said, no, you go and you go to the university, you have to study. And honestly, it was not that it was my first choice, medicine. In fact, I decided to have, a go not only for medicine, but also for philosophy. So I started first year philosophy at the University of Barcelona and first year medicine. And then at the end of the year, it turned out that I had extremely good qualifications in medicine. And that's how I continued medicine, and I just forgot about philosophy. So it was, it was not a real decision. I want to become a doctor. No, I was just, I actually loved also music, but I was not allowed by my mother to go to the conservatorium to become a musician. I also love a lot painting, but the School of Arts was also forbidden by my mother to me, so I really had to go to the university, and that's how I became a doctor. Yeah.
So mothers always know best, don't they, really?
Well, she was a very intelligent woman, and I think she made the correct decision. She actually forced me to take the correct decision.
And good for all of us. So what attracted you to cardiology in terms of, the broad field of medicine? Why cardiology?
You will not believe it, but it was also by chance. Basically, when I finished the first year of medical school, I was invited by Professor Valdecasas, the professor of pharmacology, to join his team, the Scientific Research Center, which is, still there from Spain in Barcelona. And I never saw any university building anymore, except for the research laboratory and the hospital. So basically, I did not attend any lessons anymore for the next 5 years. And then during that time, I joined different departments. So I was in the rheumatology department, I was in the pharmacology department, I was in the, also in the internal medicine, in the emergency department. I was there spending many nights, to learn as a student. And also, I actually joined the hematology department of Professor Rothman. And it was a fascinating time because that was the time you might remember that the so-called Haiti leukemia was discovered, and our team in Barcelona was part of the team discovering this very, very funny type of leukemia, the Haiti leukemia. The cells of this cancer, they have like hairs. It's like if they have hairs like you, basically. And so I was fascinated by hematology. But then when I finished medicine, went to the mountains with my wife at that time, who was also a doctor, and we became general practitioners for 6 months. And then we went back to the university hospital for internal medicine. And when I finished, at that time it was only 2 years internal medicine, I wanted to become a hematologist, but I was very young. And basically, Professor Rothman said to me, you have to wait for 1 year. But yeah, it was impossible because my wife was pregnant, we had no insurance, we had no job or anything. And there was a position in cardiology, and that's how I became a cardiologist, simply because I needed to work, basically.
A lot of chance going on then in your life.
Yeah.
So the Brugada syndrome, how did that come about? How did you discover it?
Well, basically, that many of the discoveries in medicine and in science in general, they are a combination of good luck, the good luck of having something, and serendipity, what is called now, this very famous. That you start looking for something, and at the end of the road you come out with something completely different, but you find something. That what happened is, in the good luck part was that I had the visit of this Polish child with a father. He was 3 years of age at the University of Maastricht at the time that I was working there with Professor Wellens. And he just came from Poland. 1986, they crossed the border completely illegally. You know that the wall of Berlin disappeared in '89, so it was still the time of the Cold War and everything. So basically, this child was admitted at our hospital, and he had this very funny electrocardiogram, and he had these episodes of sudden cardiac death that, thanks to the training of the father, he survived many of them. And we had also the good luck, in some way bad luck, but good luck, that the sister also had a cardiac arrest and had been visited in Warsaw, in Poland.
Okay.
And I could get the medical records of the sister, and it turned out to have exactly the same electrocardiogram. Well, at that time, of course, these were only 2 patients, but in the next 5 years, I was able to collect 2 other patients, one patient from Belgium and one from the Netherlands. And there we had the first abstract. To be honest, we thought that it was a curiosity, we never expected this to become what it has become, and to really have an impact in cardiology and in medicine in general, because it has had a real impact. But it was, in some way, there's a combination of good luck, and I think that curiosity. To be honest, I was extremely fascinated by these electrocardiograms. I could not understand anything. I searched everywhere. There was no publication about that. And when you think, the electrocardiogram existed at that time for more than 80 years, and that nothing in the medical literature was available on this pattern. And in this pattern, that actually was associated to sudden cardiac death, and in children, young people, and familiar, everything was there from the very beginning with these 4 patients. And then, basically, when we presented the abstract in NASPI in the United States, then the colleagues, my fellows, etc., that came, they said, I think I have a patient like this, etc., etc. So we received many electrocardiograms, and we found 4 additional ones that really were identical to what we have seen. And finally, the publication in '92 included 8 patients. Curiously, 3 of the 8 patients were children, actually, at that time already.
Okay. So it must be an amazing feeling now to look back and know that you discovered a syndrome that everyone can now use. It must be a great feeling, and not many people actually get to do that or have done that.
Well, it is, to be honest, it's a real honor that I had the good luck to come across with this patient. And to be honest, I'm very surprised that this, what, to be honest, we thought was a curiosity, has become a major issue, because that markers of Brugada syndrome, when you go to the new technologies of genetic analysis, are found very frequently. I don't mean by that all these patients or all these individuals have Brugada syndrome or that will suffer sudden cardiac death, but it has become evident that this was not a curiosity of 8 patients, but it was simply a very important problem. And as you know very well, this is even endemic in some areas of the world, like from Japan to Thailand, and the whole Philippines, etc. That is even called endemic, because there are publications stating that 1 in 100 men in Thailand has Brugada syndrome, which is incredible.
It is incredible.
Yeah.
Looking back on your career as well, when we talked before, you mentioned that there was another highlight to do with the Romano syndrome and the 50th anniversary. Can you tell us a little bit about that?
Well, yeah, I was very honored. The Irish Society of Cardiology invited me to give a talk during a meeting that was 2 years ago, 2014, which was meant to honor Dr. Ward. And Dr. Ward, as you know very well, he's the co-discoverer of the Romano-Ward syndrome, which is the long QT syndrome, of course.
Yes.
And long QT syndrome is, it's also a paradigm. It has touches a lot of things in terms of arrhythmias, sudden death, ionic mechanisms, etc., etc. So it was incredible because it was the 50th anniversary of the discovery of the Romano-Ward syndrome, and Dr. Ward himself, at 91 years of age, gave a lecture, and he showed the first electrocardiograms of the girl, actually, that had the long QT syndrome, with the torsado de plantas and everything. And it was fascinating, of course, to take a picture with him, which I really keep very close to my heart, because it's an exceptional person. Also, it's a very nice, really beautiful, beautiful person, and he gave a really very emotional lecture about the discovery of this syndrome 50 years before. Yeah.
It sounds fantastic. We're two amazing people in the same room by the sounds of it. Can you, going forwards now, can you tell us a little bit what you expect we will see in our lifetime now in terms of advances in cardiology?
Well, if I could tell you what the truth is in the next years, of course, then I'll be a billionaire already. So what I can do, only thing I can do is look back at the past. And just if I'm now 35 years cardiologist. Yeah? And then if you tell me what do you think about what has happened, or in other words, you will say, just move back 35 years ago and try to predict what has happened in these 35 years. Incredible. I come from the time when a patient had a myocardial infarction. It was meant to, just stay away of the patient. So the patient was put in the coronary care unit. We didn't touch the patient. He did not move. Everything was forbidden because we were afraid that everything would get broken and the patient will die. Now, if you see nowadays a patient with a myocardial infarction here in Belgium, we have a hospital on each corner of the street. Yeah.
Yes.
When the patient gets chest pain, gets into the hospital and gets immediately a PCI, a stenting of the coronary artery, and next day he's home and there is no myocardial infarction. That's basically, this was unthinkable.
Incredible.
I mean, I have seen the times of the streptokinase, the thrombolysis.
Yes.
I performed the first thrombolysis in the Netherlands myself, by the way. And just in the area of coronary artery disease, the advances have been incredible. Look at arrhythmias. In 35 years ago, the implantable defibrillator did not exist. It was just the first. It came in 1980. So I can tell you, I have seen my patients with arrhythmias post myocardial infarction. I started the 1st of January with 100 patients, and at the 31st of December of the same year, I was left only with 65 of these patients. So the 1 year mortality rate, when I started cardiology of these patients was 35%. That was much worse than cancer, much worse than cancer.
That puts it in perspective.
Nowadays, my patients, I do not say that they do not die, but it's incredible. They get the defibrillator, implantable defibrillator, and they are treated. First of all, we have no myocardial infarctions anymore, particularly here in this dense population of crowded country of Belgium with so many hospitals. When they have a myocardial infarction, we can protect them with excellent medicines that we did not have in the past. And what we see also, if we need a defibrillator, this defibrillator will protect them absolutely, without any doubt, against sudden cardiac death. So if I had to predict that 35 years ago, I could not. Nobody could predict that.
No.
Look at imaging in cardiology. The cardiac MRI, the CT, the CT scans that we are able to do at the present time, so that we can study non-invasively the coronary arteries. That's incredible. Look at the percutaneous techniques. Ablation not only did not exist 35 years ago, but we would even not ever think of, doing something to atrial fibrillation. And nowadays, in our laboratory here, the first and most important job that we do every single day is ablation of atrial fibrillation. That's the largest population that we have at the present time. Of course, we have AV nodal tachycardias, Wolff Parkinson White, but the largest population is atrial fibrillation ablation. Who would have said, at any point in time, that we would be able to cryo-ablate in the heart, to freeze the pulmonary veins, for instance, with a balloon, or that we would be able to burn several areas, endocardially, epicardially, anything you like. So now, if you tell me what is going to happen in the next years, well, I think that what is going to happen is that this technology is going to get better and better and better in terms of miniaturization. Is going to get, you have seen now the start already of the leadless pacemaker, In fact, I designed the leadless pacemaker in 1983, and the idea was rejected by the company that I approached at that time. Because, they considered that this was impossible to be done. I still have, the whole drawings of 1983. And now it's there, so I'm very happy. Okay, I don't have the patent, I don't have the money, or I will not receive the money, doesn't matter, okay, I'm okay. But in 1983, I did that. I actually designed a mini pacemaker to be implanted inside the heart with without a lead, And it's exactly the same design that you see at the present time.
Okay.
So, but what is going to happen, I think, is that in the technology, we are going to see, I hope that we see that we are going to move more to a preventive way of treating all these problems.
Yes.
But what do I mean by that? Nowadays, for instance, if we monitor someone, it's because there has been some problem.
Sure.
Now, just look at me, myself. I'm now, say, 63. This year I will become 64 years of age. You tell me what can happen to me now. Mm-hmm. Three things. Either I have an accident, fine, good, okay, it can happen. Mm-hmm. Either I get cancer, mm-hmm. Or I get a myocardial infarction and die suddenly, okay? Now, if we just take this last one, which is still number one cause of death in the Western world, mm-hmm. If you tell to me, okay, Pedro, I have for you a chip that we can implant subcutaneously, mm-hmm. which monitors a series of parameters. For instance, your heart rate, it can measure the body temperature if it's necessary, movement, so that if you fall because you have a syncope, mm-hmm. it will detect that you are falling down, mm-hmm. etc. And it has also GPS inside, so that if you get a problem, that machine will send a signal and will send you immediately an ambulance at your house, or at the place that you are. I let it implant because I know that's one of the possible three causes of death, and this is one which actually, cancer, you can discover it, treat it, you do not die suddenly from it, but that one, myocardial infarction or any other type of cardiac problem can kill you within seconds, mm-hmm. and that's the reason that I think that we will move more and more to that. There are a lot of people around in the world, old people, that they have, something hanging on the neck, which is a button, that if they collapse or they have a problem, they can push the button. The problem is that if you collapse, mm-hmm. you cannot push the button anymore because you lost your consciousness. So that should be automatic. Yeah. And then I think that this is one of the things that will happen, that we will go more and more moving just to monitor people that do not yet have a problem, that might get a problem, but they don't have the problem at all now.
And I guess added to that, you'd have lifestyle measures, better diets, exercise, sleep, and those sorts of things would making the difference, which more and more people seem to be doing now.
Exactly. But I think that the whole revolution has already started, mm-hmm. and this we cannot stop is the whole genetic revolution. That's something. The amount of information that we are now getting about genomics and proteomics, anything you want with omics at the end, it's gigantic. We are getting the problem is that even we don't know how to handle this information. Mm-hmm. We analyze the DNA of someone and we get all these variants. What does it mean? Mm-hmm. What is important is that a disease causing variation, what we call a mutation, or this just a normal variation, mm-hmm. without clinical consequences. But also, with all this information, we are going to understand much better how to target the therapy of one individual. And by that I mean simply, that knowing exactly what is the genetic background, mm-hmm. I'm sure that we will also understand why medication works and another one doesn't work. If, for instance, in Iceland they have this huge genetic project that has shown some very simple things, like your mother has hypertension, you have hypertension. If your mother does not react to drug A, you are not going to react to drug A. No. And if your mother reacts to drug B, then you also react to drug B. And for diabetes, for everything, I think that this is going to be the real revolution, but the problem is how to interpret all this data. So bioinformatica, mm-hmm. this is the place to be for the future researchers, because with bioinformatics there will be such a lot of work to be done in all areas of medicine, not only in cardiology.
Yeah, well, it'll be interesting to keep an eye on that. I think it might be appropriate just to end, if we might, about advice you'd have for up-and-coming cardiologists, lessons learned in your career. What would be the best piece of advice you could give?
Well, first of all, that I think that you should remain a physician, and by that I mean even a general practitioner. That's what I mean by that is that don't forget the clinical aspects of medicine, because sometimes what I see with the young generation of cardiologists is that they're even forgetting to examine the patient.
Okay.
There is not only a need to examine the patient, to hear the murmurs, etc., feel the pulsation, etc. There is also very important psychological aspect for the patient. This physical contact in some way between patient and doctor, this is the holy grail of the whole relation between patient and physician. The worst thing you can have, and I see that frequently when I get patients for a second opinion, and I listen, to the carotids, for instance, and there is a murmur, and I say, oh, you have a murmur in the carotids, we'll have to analyze that. And then, they say, well, the previous cardiologist even never listened to me, to my heart. Yeah? Or if you see a patient in whom there is a blood pressure written down in the report, and then the patient says he never measured the blood pressure. I mean, this is something which is happening more and more, and that's a little bit the fault of the new technology, because the young cardiologists, they perform an echocardiogram, and they think, okay, that's fine. I have seen it all. I have seen the valves. I have seen the heart, etc. But there are other things, and I tell you, there is this psychological aspect in the contact with the patient that is extremely important, and this is getting lost in modern medicine. That's one thing. There's the clinical history. It's extremely important still. I mean, in arrhythmias, just with the clinical history, and I wrote a beautiful trilogy for The Lancet many years ago about the clinical history in patients with arrhythmias. It can tell you such a lot, just talking to the patient and asking the correct questions about the type of palpitations, whether they are regular, whether they are irregular, whether, the patient feels the palpitations in the neck, which we call the frog sign, and so forth. It gives you a diagnosis, just the clinical history in many, many patients, and it helps clarify also what you are going to do next, because you say, look, on the basis of your clinical history, I suspect that you might have that, and that's what we are going to do, because this is the most effective and rapid way to get to a proper diagnosis, a correct diagnosis, and to treat you eventually with an ablation, etc., etc. So that's part of the clinical history. I'm teaching that to the students every single year here in the medical school in Brussels, that this is essential. Now, then that's the part that I call to be still a general practitioner. A good physical examination, a good clinical history. Then, of course, you have all the new technologies, and you have, as cardiologists in this time, to be aware of how to, you have to know everything about all these things, and you have to have a good training in technologies like coronary angiography, ablations, etc. Then no problem at all. But I think that the first thing is go always by the basics of the clinical history, physical examination, with a lot of curiosity about how is my patient feeling with all this. Because if you have this curiosity to ask the patient, you will get answers, you will have a good relation with your patient, the confidence between the two will be good, and this is an essential part, basically, of the relation that, as you know very well, if it doesn't click with the patient, then you can be the best in technology, but if it doesn't click, you will never be a good physician for that patient. And then I think that as a physician, you have this clinical part, but all of us, any single doctor, should do research. Yeah, even if just basic clinical research, you have to know what happens with the patients that you see, what has happened to them. Even if you are just a simple, just general practitioner in the broadest, meaning of the word, you have to know what has happened with my patients. Because if you do not know it, you think that everything is fine, but it might not be fine. And this is a correcting mechanism. You have to know the results of your actions. And this means clinical research and education. Once you have your data, and because these data are coming from your clinical practice, then finally what you have to do is educate. And educate means from everything, from nurses to other physicians, etc. You have to be involved in the education process. And I think that you cannot, be a good physician if you are not involved in the three components of our activity.
Okay. So what I'm hearing from you, you need to remain curious and be thorough.
Absolutely.
See?
Yeah, you have always to, because otherwise you really have to be curious, and in the three areas, in the three areas of clinical work, because to get to the correct diagnosis, you have to be curious. Research, you have to be curious to know what's happening, what you are doing, what are the results of your actions, and you have to be curious in education, because when you are curious in education, you also will get to ask other people to teach you other things, you know, and in the discussions. Yeah.
Well, I feel we could talk for hours, but I'm going to have to stop there now. It's been really interesting, and thank you so much for joining us today. It's been a delight. And just for our viewers, you can get hold of more epic videos on our website in the Academy section at radcliffecardiology.com. But just to say once more, thank you so much for joining us today, and hopefully we will be able to chat again soon.
It was a real pleasure. Thank you very much.
Thank you. Bye-bye.